Hi, everybody. Welcome. This is Jen Kovich-Bordnick with the eHealth Initiative. Welcome to our webinar this afternoon, and we're delighted to have you here. Claudia, why don't we go ahead and go to the next slide so people can just see what they are here for. We're delighted to have everybody here today. This is another webinar in our series on COVID-19. Today we're going to be talking about telehealth during the COVID-19 pandemic, and we have a really incredible panel with us today and some great examples of how telehealth is being used right now to assist providers in the pandemic. I'm Jen Kovich-Bordnick, the CEO of the eHealth Initiative and Foundation. Delighted to be here with you again today in beautiful Washington, D.C. area. All of us are stuck in our houses and couches, and hopefully you are healthy and your family is healthy and staying safe, and we are certainly thinking of all of you, and we are especially thinking of our providers and our clinicians on the front lines and all of the patients who are fighting for their lives and those who are ill as well, and everyone who's really helping combat this pandemic both directly and indirectly. We know a lot of folks that we normally work with are very busy right now, so we are really happy to have those of you who could join us today for this session to talk about it. With us today, we have Andi Hila, who is the Director of Strategy Consulting with Updox. We have Mark Filiault, who's the CIO of the Connecticut Orthopaedic Specialist, Cathy Kuhn, who is the Director of Strategy of Consulting with Updox, and we've also got Eric Weidmann with us. Dr. Weidmann is the Chief Medical Officer at eMDs and is going to be talking to us again today about the different ways that telehealth is being used right now to combat this pandemic. Next slide. Couple of housekeeping items. So everyone is muted. We have a really full house today. Hundreds of people are joining us this afternoon, and way too many to show all of your beautiful faces. But we really want to hear your questions. So if you'd like to submit a question, please click on that box at the bottom of your screen. It's the Q&A box. You just click right on there and type in your question, and we will get to it at the end, as many questions as possible. If you're having a technical difficulty, there's a chat box at the bottom, and we'd like you to use that chat box for technical comments if you can't hear, audio issues, that kind of thing. And we're already getting questions about, are the presentation slides available? And yes, they are available. If you want to go to the EHI website, www.ehidc.org/resources, you will see the slides are available currently on there, and we'd be delighted to have you download those slides or any other slides from any of the webinars that you have missed recently. So the EHI mission is really to work with multiple stakeholders, and this is just a sampling of the different organizations that we work with across the nation on healthcare. And what we try to do is really pull together executives who are dealing with different issues around healthcare and technology and focus on those that are really critical, because we believe that healthcare is really about folks across the spectrum and connecting all the different pieces. And this is a sampling of some of the different organizations that we work with. Next slide, please. And our mission is really to convene executives and identify best practices that are able to transform healthcare through technology and innovation. And that's why this webinar today and the series that we're producing is really so important. If you go to the next slide. Generally, EHI works on interoperability and privacy and security and transparency issues and analytics and a whole slew of important issues to those in healthcare and technology. And we are still working on those issues, but of course we're trying to direct them all towards this COVID-19 pandemic and understanding how we can use analytics, how we can use different tools like telehealth, and how we can address all of those tools and interoperability to really help overcome this challenge right now. And today is one of those important webinars. We've got another several webinars coming up soon. We'll have one next week on April 14th looking at privacy and security, and that's going to look at a lot of the different policy changes that are currently taking place around this. April 21st, we're going to be talking about health information exchanges and how they are trying to overcome data challenges during the pandemic. And then on the 23rd, we're going to be talking about reimbursement and telehealth and different ways that you can address that. And there's certainly been a lot of changes around telehealth and reimbursement. I know we're going to touch on some of those today as well. Next slide. And I really want to thank Updox for their generosity. As many of you know, eHealth Initiative and the Foundation, we're a very small nonprofit, and we wouldn't be able to produce these programs, all these educational programs that we're doing right now without the generosity of organizations like Updox. So I'm just delighted that they are with us here today, and it's great to have a group that's really a leader in this area talking about how they're working on this on the front lines right now. And so with that, I will turn it over. Great. Andi, you're on.
Excellent. Well, first off, I just want to thank EHI for this opportunity. I want to thank all of our attendees and especially all of our panelists. We have a pretty exciting discussion here for you guys today, so we'll get right into it. So I'm Andi Hila. I'm the Director of Strategy Consulting here at Updox. I've been here for about 2 years and was, ironically enough, involved in the launch of our telehealth things with the help of many of the people on this panel. So today's presentation is going to be about telehealth. And not only during the COVID-19 pandemic, we'll talk about telehealth in general, but we'll specifically also focus on how the pandemic has accelerated the need for practices to adapt, has highlighted the demand that has been there on the patient side as well, and we'll talk through some of the common hurdles that need to be overcome and some best practices along the way. So if you go to the next slide, please. So again, just to level set with everyone, what is telehealth? When we'll be referencing it throughout this presentation, this is the definition that we'll talk about here. And I know CMS and the Connecticut Center for Health Policy has a few different variations of telehealth when they refer to live video, remote patient monitoring, mobile health, and things of the sort. We're specifically going to focus on live video for the sake of today's presentation when we refer to telehealth. So just want to make sure that we're setting the appropriate expectations up there. So if we'll go ahead and go to the next slide. And just want to dive into the benefits. So I'm sure many of you are familiar with this. We'll dive deeper into some of these topics too. But the American Telemedicine Association, who's also a leader in this, these are some of the core benefits that they highlight as well. It's that improved access. So again, if you think about even before the pandemic, people that are living in remote areas or those that are potentially, have lack of access to transportation, or even who have the need to see a clinician outside of traditional hours, there's this huge gap for access that telehealth can improve. There's many cost efficiencies that are associated with it. So as you think through everything that is typically associated with a normal visit, whether it's the staff time involved, the facility time that's involved, travel for the patient, telehealth helps remove some of these, which can lead to cost efficiencies. And then the improved quality. So this is heavily tied into that access component as well. So it's just about making sure that people throughout the continuum of their care can gain access to it. And of course, consumer demand. The pandemic definitely has highlighted this fact because many people do want to stay within their homes but still get access to care, but it has been something that's always been existent there before, which we'll discuss about as well, and how this pandemic really served as a catalyst to a lot of these things that were already set up there. As you can imagine, all of us probably use Amazon or a banking app or something, so we've been accustomed to that as a consumer, that instant need for gratification and the ability to have that convenience. And it's here in healthcare as well, so we'll talk about how we'll kind of walk through that. So if you go to the next slide, please. Just to help us paint the picture of how we got here as well, telehealth has definitely been around for quite some time. And even as, recent as 2018, there was a lot of action. 27 states plus the District of Columbia passed 65 telehealth bills into law to help restrict some of the regulations and policy when it came to who can be treated via telehealth services, how reimbursement will work, even some parity laws in between what those fees and reimbursements will be between state or government payers and commercial payers. But the reality is it still lagged. So while some states were more proactive than others, one of the biggest barriers to adoption was this clear description of what the regulation would be for who's eligible and what that reimbursement will be. And that's one thing that, given the pandemic, has really changed. And we'll talk a little bit about the recent changes by both CMS and some commercial payers to really open up those restrictions. So if we go ahead and go to the next slide. This is just one of the examples that we wanted to highlight. So CMS is starting to publish and update pretty regularly as soon as anything comes up what they will be reimbursing for during this pandemic. And so as you can see here, the types of services that they are defining, how they are defining these services, what are those common CPT or HCPCS codes that can be billed for these services, in addition to whether or not a established patient will be eligible compared to a new patient. So again, these resources are constantly starting to be updated now, given everything that's constantly changing. So we'll talk about how we can leverage some of what's out there with CMS and how some commercial payers are reacting to this as well. Again, we know that the reimbursement component is one that has been causing frustration and many questions for a lot of years now, and even now with a lot of things being loosened up, there's still many questions around that as well. So if we go to the next slide. What we want to start getting into now, and why we have these awesome panelists here that we'll get to, is these are just some common myths that we've heard here at Updox with our customers and with other healthcare organizations that we've spoken to, and we also want to use this opportunity as a way to debunk some of these myths. So it's been anything from, I have to get new computers or equipment, it's going to be hard for me to get set up with telehealth, or it's going to take my staff a long time and I just don't have that kind of time to spend on setting something up because it has to be spent on patient care. Rightfully so, that's a real concern. My patients, especially there's this common thinking that the more elderly demographic will not be able to leverage this effectively, and so we'll talk through some of that as well. And again, like we talked about, patients want that instant demand, they want that access, and while some do want to interact with face-to-face, what we're learning is very much many are willing to have a video interaction. And of course, the big one, the reimbursement question. So all of these are myths that we'll debunk along the way. But without further ado, if we'll go on to the next slide, we'll jump into our panel Q&A. So again, we're really excited to have these panelists here with us. So Dr. Weidmann, he is the Chief Medical Officer with eMDs, one of the nation's largest EHR firms. He's also a practicing physician in Austin, Texas, and is also the president of the Primary Care Network and a board chairman. Mark Filiault, he is the Chief Information Officer at Connecticut Orthopaedic Specialists. They are one of the largest and most respected orthopedic groups in both New England and the nation, and he'll have some great insight to share with some of the really innovative things they're doing there. And then Cathy Kuhn. Cathy is also a fellow Updox. She also leads up one of our strategy consulting units focused on the clinical perspective. She is a practicing pharmacist, and she has been past president of the Ohio Pharmacists Association and is current president of the American Pharmacists Association Academy of Pharmacy and Practice Management, as well as a board member. So without further ado, we're really excited to have this really dynamic panel with us today. So I'll just get into one of the first questions we have. And I'll direct this one to Dr. Weidmann and to Mark. When did you guys start using telehealth? What was the driving force? And what are some of the impacts that, this pandemic has had on it? I'll start with you, Dr. Weidmann.
Okay, thank you. Can you hear me adequately?
Yes, sir.
Okay, good. So, 2019 and 2020 were kind of the years of improving patient engagement in my mind. And meeting the patient in a venue or venues, multiple venues, that are most effective for care continuums. eMDs and Updox started development of the engagement platforms in fall of 2018 and came fully to market in roughly mid to late 19. My 9-doctor family practice clinic went live in late 2019. So we've been using the telehealth visits for our commercial patients for roughly the last 9 months. It's been a relatively small volume for appropriate visits that we thought would be useful for patient convenience, remote patient off at school or college, a medication titration visit, something that clearly was easily managed with a telehealth visit that didn't require on-site or lab support types of things. Now, the driving force, what's the driving force? Well, my original driving force was really to provide clinics and patients options and convenience that prevented the fragmented care and less than what I would call ideal care that we were seeing via the kind of generic telehealth vendors that were popping up around the country in the past 6 to 8 years. In other words, I wanted to maintain patient care relationships at home in our clinic environment in the face of marketing and technology pressures that were making it easy and accessible for them to fragment their care across different provider networks. So my personal goal is not to revolutionize the practice of medicine whatsoever, but to maintain the integrity of the care that I've been accustomed to delivering in our clinic and with our group and our practice and our patients and our community, but improve the technical support that provides and facilitates that patient-friendly care, the patient engagement. So I prefer to consider this the concept of nudging in the direction of different platforms of healthcare delivery than redirecting or disrupting in a major way. So that's what got us into it in the first place and was the original driving force. You'll hear more about, as we get into the rest of the discussion today, about the rocketing into it that the pandemic has created. Mark, how about you guys?
Well, I wish I could say that I could see the future. I can't see the future, but I began putting the pieces in place almost 2 years ago when I decided to, as the CIO of a large orthopedic group, we have 28 locations spread across Connecticut. I had thought that we were a little light in our ability to deliver certain patient engagement products, and I was dealing with 3 different products, some homegrown ourselves, and I was really intrigued by taking and adapting and adopting to a single platform that would be my patient engagement platform that could then serve as a launch pad for telehealth when it was appropriate for the group. But that was fortunate that we put the pieces in place, because when this pandemic, as it clearly is, erupted, it just happened so fast that 18 months worth of work was able to be consolidated down into to be measured in hours and days. So it all started in early March when my cell phone started going off and doctors were calling me and asking, have we thought about telehealth? And quite honestly, I had a gag order on me from the CEO to say, we're not ready to start talking about that. We're orthopedics. And we hadn't even had real serious discussions on it. But then things changed really quickly. And then I can describe kind of how that rolled out maybe a little bit later.
Yeah, absolutely. Thank you, guys. I mean, I think definitely hearing how you both were laying down the groundwork and how this kind of created the need to take advantage of that work that was laid ahead of time. And we'll definitely follow up with some of the more learnings during implementation and some of those hurdles to overcome. So if we go to the next slide. Just one thing that we also want to highlight, I mean, you heard, Dr. Weidmann and Mark talk about it as well, and even the AMA has highlighted some of those key drivers. Again, these themes should be pretty familiar now. It's that patient convenience, that work efficiency, and even now, specifically given, how many people are trying to help flatten the curve and stay home during the pandemic, just like it's important for patients to have access to their care in their homes, it's also important for clinicians to be able to provide care remotely while still improving those relationships. So being able to do all of this will help increase that patient safety. And, like we mentioned, with the loosening of a lot of these regulations, a new stream of revenue, and honestly, we'll talk about this a little later too, is how, will telehealth be here to stay in the long run. A new stream of revenue and a new way to practice is probably not that far, down the path, because it's kind of here today and many people's expectations are shifting to it. So again, just want to reiterate what you're hearing from Dr. Weidmann, from Mark, and the rest of the team, and what even the AMA is saying are very similar things, which is really important. So if we go to the next slide, another question now. So this one will be, for Cathy and for Dr. Weidmann, too, is, during the pandemic, what are some of the ways that physicians are using it from a clinical perspective, and what types of visits and calls? So, I mean, Dr. Weidmann, you're a practicing physician. On top of all the other things that you do, can you elaborate a little bit on this?
Sure. Let me kind of frame a little logic that we've been looking at. So prior to pandemic, the logical care visit that would be really good for a telehealth visit is not a sore throat or a cough or the kind of usual things, ear infection in kids. Those really are best served face-to-face with some judgment about examination. There were the titration things I mentioned earlier. And if I jump back to yesteryear, the physicians that retired shortly after I came into practice 30 years ago, a lot of them manage things with phone triage and highly sophisticated phone triage, if not be on the phone themselves. They would say, yeah, do this and call me if it doesn't work, or come into the office this afternoon because I need to see that. So this is not innovatively different with the pandemic that is now leveraged for us in our clinic to protect our patient care delivery system so we can live to take care of patients another day, so we can survive and not shut down with dirty building and sick employees. So we have now just literally, the catalyst has put us into using the telehealth often as a triage for anybody who's anywhere close to coronavirus contagious type symptoms. So we queue up and triage with telehealth and phone, and then manage either in safe place and safe rooms or in regular clinic environment if there's a low contagion risk currently. So that has been very successful at us maintaining our family medicine regular care as well as caring for ill or questionably ill patients. So that's the acute triage and the keeping operations going. Now, how has it been received? Well, the reluctant and the quarantine patients are often offered options for telehealth visits, and we manage them best we can. The refills that we have and our regular care gap analysis, our database queries and our patient lists that have pending needs, we are literally using those to help drive appropriate telehealth visits to keep people's care going when they're not, beating down our door to get in here to see us. So quite frankly, the last thing is there's a satisfaction to getting paid for all the darn phone work we've done all these decades. Some other professions have enjoyed being able to bill for 15 minutes on the phone, and I haven't my entire 30 years of career. So there's a little bit of joy there, quite frankly. I'll end on that. Cathy, what's your perspective?
Thanks. Really, you highlighted all of it. As far as the type of clinical visits, me being a pharmacist, I always think medication titration and monitoring is an easy way to quickly adopt telehealth. And I also think that patients quickly appreciate that because those medication visits are awfully short and potentially, to them feels inconvenient to their day-to-day. Same thing you said, sick visits, some obviously require a level of physical assessment. So not all sick visits would be appropriate for telehealth. But just in general, that is a great phone triage starting point with the added visual and power that telehealth has. And then finally, the other type of form that I really see telehealth exploding is just chronic care management, specifically like in the areas of behavioral health, diabetes care. So those type of visits where maybe it's no physical assessment required or just really reinforcement and education are good vehicles or topics for telehealth conversations.
Yeah, absolutely. And thank you guys for that. And it's important to understand both what to do during a pandemic, but like you guys also mentioned, outside of pandemic, it's also important to understand what are some of the useful ways not only to use telehealth, but also get it started. And those medication questions and the titration definitely sounds like a great place for many people to consider. So along those notes, if we go to the next slide, one of the next questions we have is, implementation. I know you've heard from, a few people on this panel, some that were implementing beforehand, some that are implementing now. And one of the things that often, gets asked is what are some of the hurdles? How long did it take? just what was the true impact on staff and patients. So this will be for all our panelists, but I'll start with Mark, if you can kind of highlight your guys' approach and tell us that story.
Yeah, it was like a jet taking off. It just happened. So as I was starting to say, I started getting phone calls and texts from some of our doctors, but we actually didn't launch our program until 2.5 weeks ago on March 12th. I had put together a telemedicine plan and presented it to the CEO and the other leaders of the organization. And at that point, we were green lighted to start the onboarding. And so I sent all the information out to our doctors and explained that we now have telemedicine. We had done some testing the week prior with our partner. Thank you to Updox, because we're able to we already had the integration built. It was very easy to get it going. And so we have now successfully onboarded 53 providers and their staff in 2.5 weeks. And we saw almost 600 televisit appointments in 2.5 weeks in March, and we're well on track to see 1,200 in the month of April. It was out of necessity, it was out of need, and it started with a small handful of doctors that were out in front of this, and then it just spread very quickly because our business was collapsing and our need to stay in touch with our patients was evident, and there was a lot of use cases for it. So we rolled out the training to the staff, and we did that through a series of go-to-meeting sessions because we're a very spread out organization. We have 28 locations and 600 plus employees. So training has always been about televideo, if you will, through go-to-meeting sessions. So we tee up the PowerPoints, we walk them through, we give them the ground rules. And what we found is those groups that are teeing up the patients well to say, hey, you're going to have your appointment at this time. We're actually doing a televisit with the patient ahead of time to verify that the technology is not a problem on the other end, because we can only control half the piece of the technology. And so those groups that are working well like that and very coordinated with the doctor are having astonishing results. And I'm just amazed at how fast it happened and how successful it's been for us. Now, whether it stays in orthopedics is to be determined, but for now, it's an important way that we're staying in touch with our patients.
Absolutely. I mean, kudos to you guys. That's a large number of providers and a lot of visits in 2.5 weeks. So, I mean, that's just absolutely incredible. So many kudos.
Sleep will come next month.
Yes, exactly. How about you, Dr. Weidmann?
Our implementation was kind of slow and on interest over this past half year until the last 3 weeks when we saw this need to manage mostly the triage. And then the comfort with the platform made the rest of the providers in our group and the clinics that I'm in contact with through the rest of the eMDs families, they've, of course, rocketed off just like Mark was relaying. And it is somewhat out of a sense of survival business-wise that's being driven, but it's also very much about concern and contact for patient care and not just sweep the problems into the households where they smolder and we have a bigger mess to take care of with our patients later. So the on-ramping and the implementation, with the groups that have already implemented with most of the eMDs products, we have demographics and links feeding the Updox logins, so it's fluidly easy to access our patients. I see one of the questions that talks about, does the telehealth note integrate into the EHR? You can certainly put the note in the EHR. You can take screenshots if you want, but we don't. Why would we? We have an EHR that does a better job of record keeping than notes in a telehealth visit does. So typically, what we want is a thin, flexible, kind of platform agnostic, works on any device communication that allows us to work in our home EHR. We don't want to teach new HR functions to people. We want them to use their home systems but have a different way to communicate and interact with patients. And if they're motivated, for wound management, like Mark, I can imagine some post-op wounds, for rashes occasionally, for different, I can get a screenshot of glucose logs and put them in if patients aren't sophisticated enough to send them to me. So, yes, we are able to integrate notes in, but we rarely want to because our EHR notes are what we're accustomed to working with, works better.
Awesome. No, thank you for that. And actually, on that note, I'll also ask Cathy, as someone who is the clinical voice of Updox and works across many of our customers. I know both from what are some of the considerations when selecting one, but even to some of the items that Mark and Dr. Weidmann mentioned about when it gets to those thoughts and those big questions asked during the implementation. Can you share some more insight there?
Yeah, thanks, Andy. So just to answer this question from more of the overall voice that I hear from all of the different customers and practices, how they want to approach implementation. So a couple of the key factors that I've pulled out is really the time to implementation. There are a lot of great telehealth platforms out there, but it's critical for the implementation period to be very quick and easy so that providers adapt very quickly, patients adapt really quickly, and we can quickly, so we don't experience any unnecessary hurdles. Of course, the time investment and the money that is invested in the platform is important, but compliance with HIPAA is going to be extremely important. So obviously fielding a lot of questions around HIPAA and security should be always important for any telehealth platform. And then lastly, just feedback from others. So everybody wants to hear about what other groups have done what. I'll tell you that in Ohio, we just recently onboarded a large health system and added 5,000 new users, which is incredible. And we've been able to do that in the past 2 weeks. So again, just going back to that time to implementation, it has to be easy, and it shouldn't take months and months and months. It really should be, how can we get people on fast and quickly and not overcomplicate the process.
Cool. Thank you, Cathy. And if we go to the next slide, I think you'll hear a little bit about what each of our panelists mentioned. And this is from the AMA and also the ONC regarding important things to consider for a telehealth solution. So it's absolutely that. It's got to be HIPAA and high-tech compliant. I know there's some regulations that have been loosened now, but if you think about how this is going to progress past the pandemic, those things will be important to consider moving forward. Usability. So you heard each of our panelists mention how not only it has to be easy for the clinicians that are using it, but it also has to be easy for the patients. You have to influence behavior change on both sides, as you heard. And again, what are those differentiations that are going to be important? So as you think through, is your team, your organization going to be supported to customize it to that workflow? And we'll get to that in a second as well. And you heard Dr. Weidmann also mention it, that EHR integration. Understand what is really necessary and what isn't. And again, how do you let the EHR continue to be the place that it is, which is the record for the clinical documentation? You don't want to overwhelm clinicians and other users by training them to do the same things in yet another place. So again, those are all really important takeaways. And just to dive a little deeper, if we go into the next slide, you heard about the general approach to implementation. If you guys can all share just a little bit more detail about the staff, what are some of the day-to-day changes in their, workflow, or what are some of the maybe hurdles that they had to overcome, and what are some of the behavior changes that you're seeing now as you have implemented a telehealth solution? How is their lives different? And this could be anywhere from administrative staff to the clinicians. So again, I'll kind of start with Mark and go down the line again.
So our staff was not ready for this because we didn't have any inkling that we were going to be doing this. So when I launched the program, there was a lot of questions. But what we tried to address in the training that we did with the staff, because there was really two parts of the training. There was training that I was conducting with an assistant of mine with all of the doctors. I had to do one-on-one throughout, nights, weekends, whatever, to do the whole televisit with the doctor and teach them the mechanics of how to have, eye-to-eye contact with the patient, how to set up their environment properly, how to use the tool. And, that session was anywhere between 7 minutes and 20 minutes per doctor. I mean, they adapted very quickly. The staff, on the other hand, they had to think about the mechanics of how to tee it all up. And it wasn't a lot. And so we asked them to talk to the patient and validate, are they willing to do it? Are they a good candidate for it? And are they, please communicate to us. Do you want us to contact you on your email? Do you want us to contact you via your cell phone? Because the platform is dependent on what the patient wants and what's most appropriate for the patient. So there's a whole, what I call pre-flighting, where we have to tee it up for the provider. The last thing I want is an orthopedic surgeon sitting there waiting for the patient, because we're totally reversed, right? Because it's always the patient waiting for the orthopedic surgeon in a waiting room. Now, the surgeon has to wait for the patient. So we've totally flipped things upside down. And the staff had to work to make sure that our doctors did not have a lot of time, waiting for patients. But they're adapting to that, and they're pre-flighting, and they're getting their rhythm more in line to just stay out in front of the encounter on behalf of the providers.
Yeah, well, that's great. That's great. How about you, Dr. Weidmann?
Same kind of onboarding pains, the delays of providers waiting for patients to show up have been a challenge, and you almost have that kind of sense, and your pre-flight brings up exactly the case. My staff is starting to do where are the exits and how to buckle the seatbelt and all of that pre-flight types of things for patients to queue up and be ready. Patients get very anxious if I'm 10 minutes late calling. What broke down? What's not working? This is new to them too. So, and I have to kind of bear my head in shame, where a common wait for me in the office would be 30 minutes to 60 minutes on busy days. They're wondering right now, 5 or 10 minutes in, they're calling to say what happened. And so, it's making me up my game, quite frankly. And staff is indeed managing that issue between using cell phones and seeding databases with cell phones and connectivity on email versus cellular. Vast majority of the patients want to be contacted via their cellular number on their mobile platform, their phone, basically. So,
absolutely. And Cathy, how about you? I know you've been involved very closely with a lot of our customers as they implement this and help overcome some of the questions for their staff.
Yeah. So I really think there's 3 main critical issues for implementation is defining your workflow ahead of time. So identifying who is doing what. So I really like that term pre-flight. So, staff is helping with the pre-flight. The physician is providing the care. And then, the staff may also be helping with any other additional billing or integration with the EHR if that's necessary. But defining that workflow is truly critical. And in addition to that is with that workflow, having key defined roles that everybody has and training based off of that role or that user type. And then lastly, I think Mark alluded to this before, is that we only have control over one side of the technology. So we should fully be prepared to get tech questions from the patient. And so I know our company, we created a technical troubleshooting user guide, and that wasn't really intended just for the practice. That's really because the patients are going to face that every single day. And with so many devices, browsers, et cetera, it's hard to keep up. So just having the staff be prepared to educate the patient on what to expect and overcome any technical challenges they might have.
Yeah, no, thank you for that. And again, I just want to emphasize, the great answers our panelists mentioned, where it's anything from taking the time to pre-flight with the doctors, like Mark mentioned, and taking the time to help them understand what that experience looked like. Dr. Weidmann mentioned a great point about understand how your patients want to be communicated with, collecting those cell phone numbers, the emails, even the things like consent for any, regarding to virtual treatment and payment. Those are all very important considerations to have up front. And like what Cathy said, bringing that all together into a workflow that it's clearly well understood what each person's role is, what their expectations are to play a part of this. So if we go to the next slide, we just wanted to share some really powerful examples that we found online. And so there's some great resources we'll share at the end. But here's just a great example from the American Academy of Pediatrics that just works through, again, what their patient process would look like to request an appointment, how they would screen and determine whether a telemedicine visit would be appropriate, how someone would reach out to them ahead of time to understand, their history and go from there to determine what the next steps are. And even if we go to the next slide, this is something published by Alidade, which is one of the nation's leading ACOs, and just for full disclosure, they're also an Updox partner. But again, they put this together for their staff to go through and just go mention exactly what our panelist said earlier. What is that pre-visit workflow? What you're expecting to happen during the visit? How are you going to follow up after the visit? Where does the documentation occur? So you heard Dr. Weidmann say earlier about keeping the EHR the place for a lot of that. So how do you make sure that that burden of the clinician is limited? You heard Mark mention, how do you make sure that you take the time to educate the clinicians so that they don't go in and feel overwhelmed every time this happens because they go in feeling prepared. And then again, you heard Cathy mention, it's important just as much to set expectations with those patients. Those are really all part of this one general workflow, so it's very important to take the time and think through that. So again, thank you all for that answer. So if we go ahead to the next slide, one of the next questions we have is, how have patients reacted to this new way of practice? So again, we talked about some of those myths earlier about, are patients ready for this? Will elderly patients especially have more troubles with it? Dr. Weidmann, let's start with you. Can you kind of share some insight here?
Sure. It's been a huge win. Most patients are super satisfied and appreciative. Of course, we're in this rarefied emergency mobilization and sequestering at home. So there's a lot of emotions flying as well around that topic. But they really have appreciated it. And when a face-to-face or an in-clinic visit is needed, that ankle looks bad. I need to get an x-ray on it. Come on in. They are still super comfortable with the process and reassured. A few patients have been surprised by a bill for a visit because, again, this is so rapidly on-ramped. It's really not been allowed to have clear advance disclosures and those permissions and authorizations you talked about. So we really need to, I know at our family practice clinic, we need to up our game about that. And we're being super soft about saying, okay, we got it. It's new and different, and not chasing down people who are surprised by bills. But then there's a couple that are frustrated by the clarity of voice or the freezing of video. And I'm enough of a geek to understand that there's a million reasons. Somebody walks outside their workplace so they get some privacy, and their workplace Wi-Fi is now 1 bar, but it still takes priority over their 5 bar cellular contact on the video. And, you can't coach everybody through all those different platform variables. But for the most part, I reconnect in a moment, or if I'm having trouble getting a communication, I bail after some needed things and call them back on the phone and say, look, I didn't clearly hear what you were telling me your glucose numbers were, and the needs and the dosage and et cetera. So can you repeat that for me? And so that's worked. On to you others. What are you thinking?
Yeah. How about you, Mark?
Well, it's been about patient safety for the patients and about our staff and our provider safety. These are very difficult times. The orthopedic group was not prepared to launch telemedicine. This was forced upon us. But upon reflecting it, I believe our patients are very appreciative. It's allowed them to maintain their care with their orthopedic doctor. It could be a number of great positive examples in terms of the visit types that worked well. Is classic scenarios, you see your doctor and they may need to order more studies from a radiology perspective. They may send you out for an MRI or a CAT scan. Well, when the results of that come back, it's typically another office visit to then review the results. that's a perfect example for a televisit where the physician will explain the results and maybe be able to direct you to the radiology portal to view the images yourself. So I don't think there's any question that many of our patients appreciate it, and everybody feels safe because we're all social distancing, and we're still seeing volume, but not nearly the volume that you'd expect to see in a group of our size. So I think it's a win for sure.
Yeah, that's awesome. How about you, Cathy?
Sure. I mean, really nothing new from what everybody else has said. I think patients are really appreciative, just like providers. They feared the unknown, but now it's here, and they realize how easy and how accessible and how much it's been helping their care during this time.
Great. Yeah, so
there was a question about patient consent. Dovetailing on this, there's a question that flew in about patient consent and addressing it. And Mark, I'd be interested, I know we have just resorted to verbal consent on the fly while we revise our clinic patient consent forms to include or exclude telehealth contacts. What are you guys doing?
So we use a pre-visit platform where we try to do as much of the registration electronically through a platform that we can collect all of the consents before they even walk into the facility. So we're adapting the telehealth visit type and consents around that. But during this time, we're also relying on the verbal consent that we're asking the staff to do as well. So we will get that dialed in short order. But for now, we're focused on the verbal consent, and we've modified our templates to document that accordingly in our notes that the verbal telehealth consent was provided to the patient, that services may be billable.
Yeah, that's a great question, and thanks for calling it out, Dr. Weidmann. Kathy, can you also add, I know consent is one of the big questions we often hear as well, and I know you work closely with that.
Yeah, so consent varies really by state law. So as far as the wording goes, that can always be difficult for us to recommend. But during this COVID time in particular, CMS had stated that verbal consent is a viable choice to use. So verbal consent and then documenting in the EHR seems like the pathway that most of the practices are using. But again, choosing what those words are when they're acknowledging consent may vary by state law.
Cool, awesome, and thank you everyone, because I know definitely there's going to be a lot more consent questions and trying to figure that out. So it's definitely important to understand how others are doing it and learn from that. If we go to the next slide really quickly, again, these are just some statistics and recent surveys to highlight, even before the pandemic, many patients were willing to try virtual care encounter, and many no longer even felt obligated to stay with a clinician that didn't offer one. So again, just going back to our point, none of this is new as much as the pandemic has really accelerated and highlighted ongoing needs that were there in the healthcare industry. So it's important to adapt accordingly during this time, as hectic as it is for everyone. So we have one more question before we move on to the general Q&A. So again, this is just trying to get the thoughts of all our panelists. How do we think telehealth will change practice after the pandemic? And let's start with you, Cathy.
Sure. So I think there's going to be a lot of positive change regarding telehealth. I think right now practices as well as patients have quickly had no choice but to overcome the barriers. And so now that they overcame these barriers that they thought were issues, like I guess training staff or creating the workflow or whatnot, I mean, they've already experienced that. So so with that, I don't think we'll see the same type of, I guess, issues from the practice side of adoption. But on the flip side, I think patients, their expectations will continue to increase. Just consumer demand of realizing that telehealth is a viable option with their community providers is going to be something that the patients will will expect more from really a convenience factor, I would say. And I also think, lastly, as telehealth continues on beyond the pandemic, is that it will help us continue to transition to value-based care models, really helping that patient around that continuum of care, and helping those check-ins really be, easier to be completed so that we're not worrying about as much patient no-shows because they are able to fit in those appointments more quickly throughout the day.
Awesome. Thank you, Cathy. How about you, Mark?
I guess we don't know at this time what it's going to look like post this exercise we're through. I have spoke to a number of our doctors who are very positive about continuing on with telemedicine when we transition forward. But I've also spoke to a number of doctors who just are not sure what will happen. But I do know this, the patients are now aware of it and they've taken a bite from the apple, and I think they will be asking for the opportunity. So the question then comes back to us, what will our response be? How will we factor that? So we are going to have to establish some ground rules and be consistent with how we provide this service for what types of patients and what types of appointments across the spectrum of the organization. So that's to be determined in the months ahead.
Absolutely. Thank you, Mark. And how about you, Dr. Weidmann, both as a physician and also the Chief Medical Officer of a large EHR? What's your take on this?
There's no going backward in life, even when it feels like you might be, and you can quote me on that one. This is a global event that will rapidly catalyze many of our aspects of less personal contact to provide basic services in our world. Commercial payers already had mandates for fully paying for E&M codes in quite a few of the states, and it was growing, and the game was leveling with in-office visits nicely for many of the national payers. Medicare, being the big elephant and exception, has given us this temporary facilitation. I think that what we will find is Medicare will look again to tighten its economic belt, and if many of us can join in to clarify, to prove that we can close gaps in care better, that we can reduce some costs, we can avoid some facility charges through telehealth, that this will maintain Medicare playing the game with facilitating better patient contact. So, the days of companies providing concierge-type telehealth visits and you pay extra subscription fees as a consumer, I think those are gone. I think we just saw those exit. Telehealth visits are now, and I think forever will be, table stakes in the practice of medicine. They're going to be assumed to be part of our repertoire. So I think we have to be there. As Chief Medical Officer with eMDs, South Austin Medical Clinic, our group, we are well situated and proud to have a strong and flexible partner in Updox. So thank you guys for creating the platforms that we're successfully deploying and using.
Cool. And thank you. And thank you to all of you guys for that. And if we move on to the next slide, just to summarize what each of our fantastic panelists has said, this is important to do, and carefully and thoughtfully thinking through this practice transformation, understanding that, adding these tools and technologies isn't enough. It's just as important to think through how it's going to affect your staff, your organization, and how you adapt to those changes in patient communication. And again, understanding it's not a one-size-fits-all strategy. Like you heard many of our panelists say, what works for some patients will not work for others. So it's important to add, to steal from Dr. Weidmann, to that repertoire, making sure that you have a way to address each specific need from each specific patient and continue evolving to meet them where they are. Because if they're going to be effectively engaged, they have to be met with methods of communication that they both are accustomed to, but it's also something that the healthcare entity which is treating them is also ready to accustom them with. So again, just making sure you think through how to develop those playbooks, to think through how you prepare your staff, how you capture the information from the patients, whether it's how you contact them, their consent, how you set expectations with both sides, and how you determine what are the appropriate types of visits to have and which are not the appropriate type of visits to have. And especially thinking it through quickly in times like this, it's important to think through those considerations of what you will expect from your EHR, what will you expect from your telehealth vendor, and what are the expectations you're putting on your staff and on your patients. So again, I just want to really thank EHI for this opportunity. I want to thank our fantastic panelists. I want to thank our attendees. I think we can move forward now to the Q&A portion. I did see we had some Q&A activity there earlier, and then we'll also share this deck. So go ahead.
Yeah, Andi, I mean, I think you've covered so much in this. There's just kind of a few scattering questions here. Maybe we can do kind of a quick lightning round here in the next 5 minutes or so. Dr. Weidmann, you covered a little bit about how this has helped kind of, you've had to rethink your scheduling a little bit. How much time are you averaging in a telemed visit, and how does that compare with your average office visit?
I'm online with the patient 8.5 minutes average on the sessions I've had, and then another 3 to 5 minutes in my EHR to complete the visit and mail it closed. So that's actually a little less time than I spend in rooms and between rooms. And the other thing that's facilitated is in my workflow of queuing up the visit, that puts me at my desk, my screens to manage messaging and prescriptions while I'm waiting for the connection. That 1 to 6 minutes or so I'm waiting for a connection to complete, I'm handling other patient issues and closing out other needs for the practice. So that's what I'm seeing.
Hey, Dr. Filiault or Dr. Kuhn, could you comment on that?
From the orthopedic side, I think we're in similar range time frames of 5 to 7 minutes. And unfortunately, we're also losing some time with other appointments where we're waiting 5 to 7 minutes for the patient to show up in the room. So I think that's the biggest challenge for our doctors, because there are some that run on clockwork and there are some that run, 30 to 45 minutes late, and the patients are accepting that. But now it's turned on its head where the provider is now waiting for the patient to walk into the room. That is going to be an interesting challenge to move forward. And I think technology is going to bring us some answers in terms of how we're going to park patients in rooms for the doctor. We'll see. That's probably a feature to come.
Are any of you using other clinician, physician assistants or nurses kind of in a pre-room before they see you?
Oh, absolutely. That's all part of our pre-flighting that I talked about. Quite often, we're actually doing a telehealth visit with the patient before the doctor even contacts them, just to make sure that, the camera works, they understand the mechanics of it, they're going to expect to see the link, and then we try to tee them up in terms of the time frame of when the physician is coming. So that helps a tremendous amount to pre-flight that visit.
In terms of thinking about this long term, how do you guys feel about some of these home blood pressure cuffs or scales or kind of the tools at home? And is this too much of a liability? Or any of you guys thinking about how that might play in long term?
Yeah, I know at eMDs and in our clinic, we've looked at various strategies on data collection and what providers need and want versus getting providers spammed by how many steps somebody has in their quarter of the year as opposed to their weight and so all the other metrics. And right now, we are not looking at any file imports that we think are valuable enough. The obvious ones for outpatient care, where most of our providers kind of work on our EHRs, would be, for instance, glucose logs, glucose pump downloads, diabetes monitors, things like that. Now, and those are useful, but still not mission critical for the full data. And there are better softwares that do the analytics and the modal kind of analysis than we would build into an EHR. So not really anything specific other than the managing reports back and forth, which Updox already does.
Cathy, any comments on that?
No, not really. Nothing additional than what Dr. Weidmann already provided.
One of the questions is about kind of being able to do telehealth across state lines. And Andi, I don't know if you can comment on this perhaps, but my understanding was with the new loosening of regulations that is now, they're not going to be coming after clinicians for doing it. That's going to be more allowed, I guess.
Correct, and that is something we're hearing from our customers. And again, I mean, we're advising, and I'm sure, you know, these guys would have some good input there as well. But what we're advising them is just to make sure that they're understanding the period in which this is being loosened up, but also have a strategy to understand, you know, what that reimbursement will look like. Are those patients considered in-network? And again, if you're going to establish those types of patient visits, what is the plan for after things kind of go back to normal? So that's been our overall talking points to that, but feel free to add anything, guys.
Yeah,
this is a very sticky point. I think that providers need to be pretty comfortable with their state laws. Texas, for instance, clearly views that the license needs to be held where the patient is living and is. Now, living versus is, their permanent address versus their locale at the moment is a bit of a vagary. And, you know, this is all quite very much a moot point until there's disgruntlement or somebody being audited or a legal suit being raised for a bad outcome. So I think it's very prudent to be apprised of your state's mandates and also understanding your patient liability as you're working on it. And, you know, sitting in the geometric center of Texas, I worry less about this at this moment, but I can see other people worrying a whole lot about it because they may not have licenses to practice in the 4 states that are within 75 miles of their clinic.
Right. Any other comments on that, Mark?
I'll let that one go. Not really my role. Thank you.
Well, I know we're a couple minutes over, so I do want to just thank Updox and our panelists today for joining us. This has been a really robust discussion, and we're going to record it and keep it online for folks so that they can refer back to your experience. And thank you again for all that you are doing in this really difficult time. We really salute you and thank you. Appreciate your service. And Updox, thanks for helping to facilitate and make this all possible for them. Appreciate it.
Absolutely.
All right. And that's our
You're welcome.
session today. Thank you, everyone.
Thank you, everyone.